Can we start? Okay.
Ma'am, we are live now.
Okay.
So good afternoon, everyone, and good afternoon to all the viewers who have joined us today. And thank you so much, Sonali ma'am, for accepting the invitation to be a part of our initiative TRAZER Times. The topic for today is IVF in PCOS women. So how is it different in PCOS? So today we have with us Dr. Sonali Tawde. She is a consultant gynecologist and an ART.
Nisha, you're mute. Please unmute yourself.
Good afternoon, everyone, and good afternoon to all the viewers who have joined us today. Thank you so much for joining us today. And I thank Dr. Sonali, madam, for taking out time and being a part of our initiative, TRAZER Time, which is a knowledge initiative. And the topic for today is IVF in PCOS. How is it different, basically? So, welcome, Dr. Sonali, ma'am. And madam is a consultant gynecologist and an ART specialist. She is basically from Mumbai, and she has received a lot of awards, and she has very much interest in publications of paper, and there's a lot more to talk about, madam. Thank you so much, ma'am, for being a part of this TRAZER Time initiative. Over to you.
A very good afternoon, all of you. Thank you, Karuna, for giving me this platform to reach our patients and other audience today. PCOS has always been very close to my heart. Being my thesis topic, I was always keen to present papers related to PCOS. So this is a very special topic for me today. So we'll see how PCOS and the treatment in ART differs from those who are non-PCOS today. So are you changing the slides?
No, ma'am. Please enter or else try with the up down button, ma'am.
Yeah, I'm doing that. Not
Just
happening.
click onto the screen once, and then you will be able to.
Okay.
Right.
So the pathophysiology of PCOS, as we know, is mainly because of the hyperandrogenism, that's more of male hormone levels, and hyperinsulinemia, which comes because of the insulin resistance. This insulin resistance it is because of the decreased serum hormone binding globulin, which is produced by liver. There is increased ovarian production of androgens and disordered release of LH, FSH. So, this combination of hyperandrogenism and the altered FSH LH ratio leads to oligo or anovulation. So, the PCOS patients will initially have irregular cycles, which may be after 30 days, or regular cycles, which may be like 45-50 days when they are ovulating. But after a while, when this hormone imbalance gets worsened, then they go into anovulation. So, as we see, the GnRH, which is produced by the pituitary, has a control over LH and FSH. This increased LH through theca cell will be responsible for causing excess of androgen levels, which can lead to acne and hirsutism. The altered FSH ratio from granulosa cell leads to follicle arrest. So many of these PCOS patients will have follicles ranging from 10 to 12 millimeters, after which there is a arrest in the growth, and this leads to anovulation. Obesity, which is a prime responsible factor in PCOD, leads to more of insulin resistance. So coming to the treatment of PCOS, I mean, whenever a patient of PCOS comes to me, my counseling starts with this lifestyle modification, the dietary modification, weight reduction, and exercise, because that is a factor which is going to give them a permanent solution in PCOS. Because as we know, PCOS doesn't have a cure. It can be controlled by all these measures. The medicines help them to some extent, but unless they change their diet and other unless they focus on weight loss, these medicines are also not going to help them much. They are also at risk of diabetes, type 2 diabetes, and cardiovascular diseases. To avoid the effects of hyperinsulinemia, we give them insulin sensitizers like metformin, the myoinositol, and decairoinositol. They reduce the production of circulating androgens and protect the endometrium from effects of unopposed estrogen. So all these medicines will help them to induce ovulation and achieve pregnancy. So what is the treatment for those who are pursuing pregnancy? When they go to a ART specialist, we give them options like ovulation induction. The recent recent guidelines suggest that we can give them induction. The letrozole is nowadays the first line of treatment for ovulation induction. And if the letrozole alone is not effective, we can give them a combination of letrozole with gonadotropin, or they go for IVF if the medicines do not work for them, or they do not ovulate even after triggering at the right time. So in PCOD patients, how does IVF differ from those with non-PCO? So here the indications of IVF will be failure of non-pharmacologic like the insulin sensitizers, or the some Ayurvedic preparations are also given in PCOD, or ovulation induction drugs like letrozole, clomiphene. If they do not lead to ovulation, then those are the patients who should think of going for IVF, because the ovulation is not getting triggered. Sometimes even with gonadotropin, these patients are very difficult to stimulate. In PCOD, the pregnancy rates range between 45 to 50% after IVF. The one good thing about PCOD patients is they have quite a good number of follicles and eggs in their ovaries. Because now if you see any ART clinic, we see more of hypo responders and poor responders. Many Asian females, we are at risk of having lower MH than our Caucasian counterparts. So here, that is the we see as a positive thing about PCOS, that we will get good number of eggs and embryos. So that is for sure. But at the same time, these patients are at risk of multiple pregnancies and ovarian hyperstimulation syndrome, which is the most dreaded complication we as a ART clinician are always worried about. So, coming to our latest advances, if you see in vitro maturation, that is minimal stimulation followed by uh, oocyte retrieval at a lesser size follicles, and then let them grow in the IVF lab, get them into mature oocytes, and then use for ICSI and IVF. So that is one of the latest advances in the treatment of PCOD. So when we stimulate, we can use only gonadotropins, or letrozole combined with gonadotropins combined with GnRH analogs, or the preferred choice is gonadotropins with antagonists. So the dosage of gonadotropins will depend upon the age of the patient, whether she is less than 30 or between 30 to 35 or more than 35. So accordingly, we start with a very low dose in some patients like 37.5, 50 or 75 IU when we know that they are hyper responders. If they are normal responders, then we can start with 150 international units. If she is between 30 to 35, then in hyper responders, better to start with 75 or 100 IU. In a normal responder, 150 international units. If she is above 35, then you can start with 150 IU, and in normal responders, start with 225 IU. This dose also depends on their BMI, that is body mass index, the AMH, antral follicle count, and their response to previous stimulation, which is also a guide to how they have responded in for gonadotropins. So, which gonadotropins we can use in PCOS? That is very much a personal choice. We can use HMG or REC-FSH. In PCOS, as we know, the LH levels are already elevated, so they are detrimental to reproductive function. So we can start with only FSH products, but in the later half of the stimulation, we do need some part of LH for priming the follicles. So there are different protocols when we see in PCOS. The step-up protocol, which starts with a low dose like 75 units, and then every 7 days you can increase the dose by 37.5 IU. Or you can go for a step-down protocol where you start with 150 and then every 7 days you can reduce the dose. And sequential protocol where you go on increasing the dose, and after a while, once the follicle reach 14 millimeters, you can reduce the dose. The preferred choice in PCOS patients is always a step-up protocol, because we want to start with a little lower dose, which will be one of the ways of preventing OHSs, so that the recruitment is limited. There is another protocol which is gaining popularity now, where we use GnRH antagonist in first 3 days. So that is day 1, 2, 3 of the cycle, or day 2, 3, 4 of the cycle, and then we start with the gonadotropin in stimulation. So that is proven to reduce the risk of ovarian hyperstimulation. It is shown that it gives more of mature or M2 oocytes, more 2PN embryos, and higher pregnancy rate. It has also shown to reduce the risk of moderate to severe OHSs and giving higher clinical pregnancy rate per embryo transfer. So when we give antagonists, there are two ways we can start. Once the follicles reach the 14 millimeter size, that is the time we can start, or a fixed protocol wherein we start antagonists on day 6 of the stimulation, or early antagonists wherein we start on day 1 and we continue throughout the stimulation. The long agonist protocol, wherein we used to start agonist in the previous cycle and then continue half the dose once the stimulation starts, that is not now currently used in PCOS stimulation. So now the current advances in stimulation protocols also includes dual stimulation or embryo pooling. So we have flexibility in starting the ovarian stimulation in different phases of the menstrual cycle, because previously we used to think that only a single coat of antral follicle is going to grow at the beginning of the follicle phase, and so we start on day 2 and continue the stimulation. But the recent advances have proven that there are 2 or 3 waves of follicle growth in each cycle. So even if you stimulate in the luteal phase, you are going to get good number of follicles and oocytes. So they have shown to have a similar developmental potential. So this control ovarian stimulation can be started on any day of the menstrual cycle, and there has been no differences when the stimulation was started in early follicular phase or late follicular phase or luteal phase. Also, there is no difference in the number of mature oocytes and viable embryo rate per oocyte, and the implantation as well as the pregnancy rates. In some patients, we have seen that the luteal phase stimulation has given better M2 oocytes, especially in hypo responders. This is not about PCOS, but in hypo or poor responders, and the embryo quality was better than the follicular stimulation. So in trigger, now we can give double trigger, which is giving the agonist trigger around 40 hours before the stimulation and HCG 34 hours before the oocyte retrieval, or dual trigger, wherein we give both of them together around 34 to 36 hours before the oocyte retrieval. In PCOS, the preferred choice of trigger is only agonist trigger. That may be triptorelin or buserelin. So if you compare the triggers, HCG has a very long half-life. So the levels are detectable up to 7 to 14 days after the injection. And it has the advantage is it has luteotropic effect. So it supports the pregnancy. GnRH analog, on the contrary, has a very short half-life, which is 4 hours. It produces LH and FSH surge, which is similar to those seen in a normal ovulatory cycle. So this mimics the physiological trigger, and because of the shorter duration of action, there is a quick luteolysis. So if you're planning a fresh embryo transfer in that cycle, you have to give very robust luteal phase support. What are the indications of this dual trigger? So if you have seen case of empty follicle syndrome, wherein we fail to retrieve oocytes in the patients undergoing stimulation with at least 5 mature follicles on the follicle scan, which are more than 15 but and you have triggered with HCG, but you have not got any mature oocytes or any oocytes for that say. There we call it as a empty follicle syndrome, which is a genuine EFS. So that means you have checked the action of HCG and the levels are good. But in spite of all this, there are no oocytes which are retrieved. So that genuine EFS we try to give the dual trigger in the next stimulation. And also when you have got a lot of immature oocytes, lot of GVs and M1 oocytes in the previous stimulation, in spite of a good size follicles which you have seen on scan. So these patients will help by dual trigger and improve the rate of mature oocytes retrieved. In case of normal responders, we can give GnRH analog along with HCG, which improves the live birth rate, and now that is the choice of trigger for most of our patients in normal and hypo responders, a dual trigger. Also, it gives a higher number of embryos of better quality. So when we are giving stimulation, we always take into consideration these factors, whether she is a PCOS, whether she is a mild, moderate or a severe PCOS, what is the age, what is AMH, what is the BMI, along with antral follicle count and history of previous OHSS or response to previous stimulation. So considering all these factors, we plan the stimulation. So, but our OHSS, which is, we can say, it is a common possibility in PCO stimulation. We try to avoid it as far as possible. And the predisposing factors for OHSS are a patient who is young, less than 30 years, severe PCO patients, those who are lean, but still they are PCO, which is like 10 to 20% of PCO patients, AMH more than 6 nanogram per ml, and if she has a history of previous OHSS, then it is likely to recur. And before trigger, if the estradiol levels are more than 3000, then these are the patients who are likely to go into OHSS. So how do we prevent OHSS? I mean, now that is very important for ART clinicians to know. Now the choice of stimulation for PCO patients is antagonist protocol, because there we can avoid giving HCG trigger and give only agonist trigger and freeze the embryos in the fresh cycle to be transferred in the later FET cycle. Here we can start with a low dose and step up the dose as per requirement and monitor her pack cell volume, PCV, estradiol levels, and if the patient's if she develops any symptoms. So accordingly you can decide the trigger and the time the trigger properly. So to conclude, when we have a patient of PCO and we are planning IVF, so these are the points we should remember. Almost 30% of the females visiting our clinics have PCOD. Ovulation induction is always the first line treatment, and now letrozole is the drug of choice for PCO patients. Weight loss, lifestyle modification is very, very important. Please focus and allot some time in counseling PCOD patients, because this is a disorder which is lifestyle related, and this tendency is going to stay with these females till they are menstruating. So even if they get their cycles regular, they conceive, even later they have to always have this in mind, at the back of the mind, that they have a tendency of PCOD and they should always have a healthy lifestyle to keep the things away. Insulin sensitizers may help. If ovulation induction fails, then IVF is the choice of treatment for these patients. In IVF, antagonist protocol with agonist trigger is the best choice to avoid late OHSs. Early OHSs, yes, mild, it can still happen even with agonist trigger, but that can be very well treated with different modalities. But the late OHSs, which happens after conception, that is prevented by freeze all policy. So it is now worldwide accepted treatment for PCOD. And multiple pregnancy and OHSs are the two risk factors we have to always keep in mind for PCOS patients. So this is all we want to tell you about IVF in PCOS patients. Thank you so much.
Thank you so much, ma'am. Thank you for elaborating the IVF and PCOS, what are the protocols and how the ovulation induction happens. And ma'am, a question from our side, like there are a lot of patients who will be suffering from PCOS and they will be struggling. And once they get detected that they have been suffering from PCOS, and that is only they come to know when they are trying for fertility.
Correct.
So, what would be your suggestion for the patients who are suffering from PCOS and who are trying for fertility? How should that be maintained? How should they follow the lifestyle?
See, first of all, we have seen many females who never they were never aware of the menstrual irregularities and PCOD before marriage, and after marriage they come to know about it because they want to conceive, and then they undergo investigation. So we need lot of awareness about PCOD, because almost 25 to 30% of adolescent girls are now facing these issues, and they, some of them are aware because they are more worried about their looks and cosmetic part, because they start developing hirsutism and acne, and because of that they see a specialist, and then they come to know about these hormonal issues. So the alertness and the sensitization part should start from that age, so that from there onwards they have a healthy lifestyle. Because of, I mean, nowadays the teenagers have hardly any physical activities, so it
True.
starts from there. So, I mean, inculcating those healthy lifestyles should start from that age, and that should be continued even after marriage, and I mean, before planning pregnancy, so that at least we'll not see so much of moderate and severe PCOD. Even if they come to us in the initial stages, that is the stage when it is reversible. Nowadays, if we see a female who is almost like 5 feet and 2 inches height, and the weight is between 80 to 90, so for them, even counseling them and, I mean, getting them back to their normal weight becomes very impractical. I mean, and they have very time constraints, since they are, most of them are working, so they
Right.
cannot focus on their diet and lifestyle modification. So if they are caught at the early stage, if they see a doctor, and that is a stage where even they are motivated, and they will look into it, that they don't gain further. So I mean, see, and my major counseling is goes for diet, because exercise they may or may not be able to do because of the time constraint, but even if they focus on diet, to me, I mean, it corrects at least 70% of the factors. So
True.
they can consult a proper dietitian, but even if they I mean, they stop eating junk and start eating healthy
That
food,
rectifies much.
that works wonders. I mean, I have seen some of my patients losing almost like 3 to 4 kgs in a month, and in 3 to 4 months, their entire lookout changes. I mean, they feel the difference. I mean, they feel so energetic and like
Right.
they were before. So all these things, I mean, it comes after motivation, but as a clinician, I always love to counsel them for this, because that is one thing that is going to stay with them, because this
Hmm.
information they may not get on any social media, or I don't know, because many of them are not aware of the cause of PCOD. They are being treated symptomatically, just
Right,
giving
right.
OC pills and just giving withdrawal for getting menses every month. That's not going to solve their problem for PCOD. They need these insulin sensitizers, like we have this TRAZER F, and this is a very good combination of medicines. I mean, I have always used this since my, I think, last 10 to 12 years, and this is one of the earliest brands we had. So they need this treatment, but along with treatment, they need these lifestyle changes. Only treatment will show the effect, but it will take a long time.
But there are also, ma'am, a few patients who think that if I'm suffering from PCOS, IVF is only the solution because I may not get pregnant, because they would be trying, and because of the like the time constraint, as you said, they don't have time. When they they come to know that they have been suffering from PCOS, and they hurry for fertility.
Correct.
Yes.
So that's not the case actually. Some patients, you can say around 30 to 40% of PCOS patients go for IVF, but other patients, if they work really hard on their lifestyle modification and they are very consistent with their treatment, like insulin sensitizer, many of them we have seen, like if there is no issue with the male partner and the semen analysis and other things are normal, many of them have conceived with simple forms of treatment, or even just weight loss has uh, given them natural pregnancies. So that's not the case that if you have PCOD, then you have to go for IVF. That's not true.
That's true. Thank you so much, ma'am, with this, because you have very well explained about PCOS, and the management of PCOS and consulting the doctor is the best first thing the patient has to
Yes, I mean,
initiate.
that is the message we should pass on, because many of them start getting symptoms in young age. So right from then, you should focus on the treatment, be very consistent, and give it a time, because PCOD cannot be corrected in like 2 or 3 months time. This it develops over the period of months and years, so it will take little time. So have patience, but it will happen once you are motivated. It will definitely get controlled.
Yes, the inner will of
Correct.
having a proper lifestyle would actually correct all the things.
Yes,
So,
yes.
with this, thank you so much, ma'am. Thank you for being a part of this Treasure Time initiative and letting us know about the PCOS. And thank you for also answering the questions related to how lifestyle is important. Not IVF is not only the solution, there is also the lifestyle modification and also the medication. And consulting the gynecologist, the best first thing the patient has to
Yes.
initiate. With this, I again thank you for joining, and all the viewers who have joined us today live, who are watching us. Thank you so much. If there are any queries regarding the talk, you can just post it in the comment section of YouTube. So the questions will be answered further. Thank you a lot. Thanks a lot.
Thank you, Nisha. Thank you, Karuna, for this wonderful initiative. Thank you so much.
Thanks, ma'am.